I wanted to give a story to echo, and I'm sure what a lot of you have been through in terms of the time it took to the diagnosis, that I'm hoping is going to change based on the work that you guys are doing. I had a patient who came to me, she already knew what she had. She had gone online and she had looked it up, and she had spoken in an online forum with other people who had gone through what she had gone through, and she had an idea of what she wanted, what kind of treatment she wanted, and so it took her a year. I was going to say only a year, but we mentioned how 4 months was so excruciating. Of course, it was difficult for her, but it wasn't the the average of 3-4 years and 5-6 neurologists or anything like that. So I'm hopeful for the future that the work that you guys are doing in terms of education and advocacy is going to help cut down that time to diagnosis and getting people the treatment that they need. So today, my focus is going to be about treatment options. I'm going to be talking just very briefly about physical therapy and supportive options because we have Chelsea here who's going to be going into more detail on that. I'll be talking about medication options, injectable therapies, and I'm also briefly going to just touch on surgical options if we have time, as well as other potential future therapies. So in terms of physical therapy and supportive options, utilizing the sensory trick as Dr. Fry mentioned, I see people here who already, people already sort of come in knowing that. But what people may not be aware of are the, the types of adaptive devices to make a chair into a high back chair for somebody who finds touching the back of their head to be a helpful sensory trick. Some people I see using neck braces, and I just want to caution people about the risk of developing weakness with prolonged or chronic use of a neck brace, but that can be helpful for some people. In terms of physical therapy, there are some studies that show that adding physical therapy to botulinum toxin injection may reduce disability and pain compared to botulinum toxin injection alone, and it may also prolong the duration of action of botulinum toxin injection. However, I would sort of caution, because some of the patients who have come to see me, or some of you may have had experience with physical therapy before it was diagnosed as cervical dystonia and when it was just called neck pain or what have you. When you're going to somebody who doesn't necessarily know what they're treating or isn't familiar with cervical dystonia, they may not have as much to offer from a physical therapy perspective. And I would caution to make sure that you have the diagnosis, well, obviously you all do, but in general terms, to go in with the diagnosis clear rather than it's cervical spondylosis or arthritis or neck pain, which might be treated differently. And I encourage you to seek out neuro-specific physical therapists, somebody who really knows the condition. And I'm going to again give a plug to Chelsea and her team at Reactive. I think they're fantastic. There is a large blinded randomized control trial. Is there any way to pull this up a bit so I'm not leaning forward so much? Maybe it's this thing here. Did Justin step out again? Okay, here we go, I think. Maybe that's not doing it. Okay, well, if we could find Justin, I'd appreciate that. So I'm sort of changing my posture, and I know you guys are sensitive to that. So there is a large blinded randomized control trial being done in the Netherlands to assess whether longer physical therapy sessions with emphasis on self-management techniques may be more helpful than traditional physical therapy alone. So occupational therapy focuses on adaptation of the days, the sort of the types of things that you might need to do in your day-to-day to try to improve quality of life from that perspective. Medication options, so these tend not to be incredibly popular because of the potential side effects of systemic medications when the dystonia is focal, as in cervical dystonia. Thank you, Justin. But it can be useful to supplement the effectivity. Oh, that's much better. Thank you very much. everybody can hear me, yes? It can be useful to supplement the effectiveness in botulinum toxin if necessary. So they include anticholinergics such as trihexyphenidyl, which is artane, or benztropine, which is cogentin. But especially in the older population, this can carry a risk of side effect, including confusion, dry mouth, constipation, blurry vision, and urinary retention, which can be very serious. Patients often will use, rather than the anticholinergics, will have tried the GABA-acting medications, GABA being an inhibitory neurotransmitter in the brain. So baclofen and benzodiazepines are commonly used, so clonazepam, diazepam. Those are also known as Klonopin and Valium, as well as Ativan, which is lorazepam. And these three, as well as cyclobenzaprine, which is a different type of muscle relaxant. These medications can cause weakness as well as confusion or sedation or people feeling foggy, where they can tell it's helping, but they just don't feel as sharp. So that's why they can be of more limited use in patients with cervical dystonia. Other impacts that cervical dystonia have on your quality of life, including what we call non-motor symptoms. So pain, of course, is a big part of it. And it's important to note that sometimes pain is also impacted by other things that are going on. For example, with orthopedic complications such as cervical spondylosis or arthritis, but also, if there's depression or anxiety, that can also contribute to or exacerbate chronic pain. And pain may also improve, of course, with treatment of the dystonia itself, but because of some people who've had chronic conditions with pain, there are things like peripheral sensitization and central sensitization, which refers to how pain is manifesting and being interpreted in the brain. The pain in and of itself may need to have separate treatment other than the treatment of the dystonia itself. That is to say, sometimes objectively, the dystonia, like the angles and everything, may have improved significantly, but there may not be as much improvement in the pain because of those other pathways of pain. So that's an important consideration. And then depression and anxiety are often present, and again, similarly to the pain, may improve with just treatment of the dystonia itself, but in some cases may not, and should be addressed separately. So getting into the injectables, so botulinum neurotoxin, or neurotoxin for short, because that's too long to say quickly. Of course, this is derived from the same thing that causes botulism. So I think this is a group that is sort of more familiar with and comfortable with the idea of neurotoxins. But when you first bring it up, or when you guys first heard about it, I'm sure it's pretty, scary to think about. I'm sorry, did you just say toxin? You're injecting a toxin? That sounds like not a good idea. But it's been in use for 4 decades now, and for multiple medical conditions. The way it works is by interrupting the communication between the nerve and the muscle. Little bit more nitty-gritty if we're interested about exactly how it does that. But bottom line is that onset typically requires about 3 to 7 days, and then the duration of action is typically 10 to 14 weeks, so about 3 months. The concept is, so this is just, I think a quicker diagram about what naturally happens in terms of the proteins coming together, forming a complex, and then what's called a synaptic vesicle, which is like kind of a little ball of neurotransmitter coming and fusing with the membrane of the nerve, and then the green dots represent the acetylcholine, which is the neurotransmitter, getting released into the space between the nerve and the muscle, and then thereby activating the muscle. And so what we want to do is, I'll skip ahead just one slide, is block that by cutting off the ability of that complex to form, preventing that vesicle from fusing with the membrane of the nerve, and therefore reducing the amount of acetylcholine that's released from the nerve, and therefore not allowing that muscle to activate. And then the clinical effect is essentially weakness. It's the same reason why it works for wrinkles, because wrinkles are caused by muscles. So it's not a filler. It's not like Juvederm or collagen or something like that. It works by relaxing overactive muscle. I'm going to step back to, different types of neurotoxins. So Botox is the most well-known, that is Botulinum toxin A. The other toxins that are commonly used for cervical dystonia include Botulinum toxin A, which is Xeomin, Botulinum toxin A, which is Dysport, and Botulinum toxin B, which is Myoblock. So you can see that 3 of them are toxin A's, 1 of them is a toxin B. So the first 3 act on the same protein versus, which is SNAP25, versus the Myoblock works on a different protein in that same complex. Comparing the 4, Botulinum toxin A, Botox, has, looking at sort of the protein complex size and the typical dose for cervical dystonia and the risk of formation of antibodies. So what happens is that there's the toxin itself, and then there are the complexing proteins that go along with it. And the larger the protein, or the more complexing proteins that are associated with the toxin, the more the risk of forming antibodies. Antibodies means your body is building up resistance to the injected treatment, and therefore making it less effective over time. By and large, as you can see, it's a very low risk with Botox and Dysport, 1 to 3%, and that risk is usually mitigated by spacing out the injections every 12 weeks. However, it can occur, and it can occur with higher frequency with Myoblock. The other differences in terms of the dosage have to do with, just to sort of finish out that thought about the antibodies, because Xeomin has a smaller protein that is, say, toxin size and doesn't have any of the associated or complexing proteins, to date there have not been any reports of any antibodies forming against Xeomin, suggesting that Xeomin could be used more frequently than every 12 weeks if needed, because of that, not having that risk of antibody formation. The other point about the differences between the toxins is that you see the dosage differences in terms of Botulinum toxin A, Botulinum toxin A being fairly similar in the dosages that are used, versus Dysport requiring about a 3-to-1 ratio, and that's because of the albumin in the formulation, and more of the toxin sticks to the vial, the glass of the vial, or the plastic of the syringe. So you need a 3-to-1 dosage to get the right amount into the muscle, versus quite a higher ratio with Myoblock, about 40-to-1, because, as I mentioned, it works on a different protein. It works on synaptobremin, not SNAP25. So therefore, that actually doesn't have as much affinity in humans compared to in animal models. So that's where these dosages are coming from. Because Judy already went over this, I did want to add that in addition to these 4 positions, there are also other kinds of shifts that patients will note and can be objectively measured, such as sagittal shift, which is sort of a side-to-side shift. I can't do very well. And then an anterior shift or backwards shift, or the posterior shift. So that's different from anthropolis, which is chin up. It would be like chin forward or chin back. So those other 4 directions that are not quite, of course, not as common, but are important things for the movement disorders neurologist or the treating physician to keep in mind when thinking about what the proper botulinum toxin injection pattern should be. So some before and after pictures. As you know, the benefits are reduced spasm, a more neutral position, reduced pain, improved quality of life, improved functioning. Prevention of contractures is really important. Dr. Fry mentioned the orthopedic complications of spondylosis, meaning kind of like arthritis of the spine, of the bones of the spine. But I think one of the other really important things to think about is something called contractures. Contractures refers to when the muscles are so tight that you no longer can break that resistance. We see that often in people who have spasticity from a stroke, for example. Like if you guys remember Bob Dole from the 90s, when you have a contracture, it's basically, in his case, of course, it was in his arm, but the ligaments become so tight and almost calcified, you literally cannot open that. And so contractures can happen to people who have cervical dystonia with years of, misdiagnosis or under treatment, and that can be very challenging to treat. But by getting treatment early, we can prevent contractures. That's really important. And then reduced head tremor is also a possibility. There are, of course, risks involved with everything. The potential risks of neurotoxin injection include swallowing difficulty, especially when the anterior muscles are injected, or if anterior muscles are injected too low, too inferiorly. There can be spread of toxin into the muscles that control the swallowing and the level of the larynx, meaning the pharynx and larynx, and as well as in the tongue as well. Increased pain can happen. I mean, it's an injection, there's needles involved. Neck weakness, of course, is a big concern. As you know, what the toxin is intended to do is weaken overactive muscles, but there's a window. There's, you don't want to give too little, that's not effective. You don't want to give too much and cause weakness. The good thing is that the side effects are always temporary and will typically resolve far before the positive benefits of the neurotoxin wear off. And so it's usually between 2 and 4 weeks of the side effects resolving, as opposed to the effectiveness of the sort of the positive effects may last for longer, of course. Other side effect to keep in mind is incomplete resolution of dystonia. And again, some of this has to do with making sure that the proper muscle has been targeted, but even with somebody who's gone through a few injections and they've gone to a movement disorder specialist, there may be incomplete resolution due to the presence of contractures, for example. Sometimes anterocolus is harder to treat fully because the muscles involved are the ones in the front, so you don't want to cause dysphagia, so you're more limited in how much botulinum toxin you can give. The side effects are dose dependent, so that makes sense. The higher the dose, the more likely that you're going to have weakness or other side effects. And the side effects also occur because of spread of toxin to nearby muscles. So even if there is proper guidance, either EMG guidance or ultrasound guidance at the time of the injection, the toxin itself may spread, may diffuse to other muscles. And there is a black box warning on the vial that you may read, and of course it's very alarming because it talks about respiratory failure and death that have occurred in people who've gotten botulinum toxin injection. The typical, those cases occurred in patients who are younger, more slender, who had cerebral palsy, and who were getting treated for spasticity of the abdominal muscles, so kind of like tight like that. And so they were having a really high dosages given to the abdominal muscles, and there was spread to the diaphragm. And then they were having respiratory failure similar to botulism. But that's really not something that's been reported with cervical dystonia because you're more limited in the dose and you're higher up. So even if there is spread of effect, it's not going to go all the way down to it's not going to be generalized spread, it's not going to go to the diaphragm or anything like that. So keys for successful injection are, first and foremost, proper understanding of the functional neuroanatomy. So which muscles are involved, what part of the muscles are involved. As we mentioned, it can get very complex, a tilt this way, a shift that way, a turn this way. So, going to somebody who really has a good handle on the neuroanatomy. The right dosage, not too high, not too low. Alignment of expectations, again, because while botulinum toxin can be very successful, when you look at the data, we're not talking about resolution, we're not talking about cure, we're talking about improvements. And then, again, I put an asterisk at the end of this in terms of limiting injections to no more than every 12 weeks to avoid the formation of antibodies. That is true of 3 of the 4 toxins, not necessarily true for Xeomin. And then people, I guess in the morning, asked about switching agents. If antibodies have formed, it may make sense to switch agents, but by and large, the efficacy tends to be very similar. So if the treatment has been unsuccessful from the beginning, and all the neuroanatomy has been properly gauged, then at that point perhaps you would call that neurotoxin resistant and discuss more advanced treatment options.